Znači sve ok. Ok. Znači tema je steroidi, corticosteroids for pneumonia, as adjuvant therapy, obviously, not as the primary treatment. It's a very interesting topic that, in a way, has occupied my professional career for about last 15 years. It's still not clear whether this should be used routinely or in some specific categories of patients. The reason for use is that corticosteroids are potent anti-inflammatory medications. Pneumonia, especially severe pneumonia, can lead to exaggerated systemic immune response. And this then can lead to organ failure, such as acute respiratory distress syndrome or total lung shutdown, or even multi-organ failure through sepsis and hypotension. This is a slide from JAMA review from last year, which is a very good review. And I just like the picture. That's why I started with it. What I want to emphasize is that there is really no unified definition of what severe pneumonia means. So different trials use different definitions. We really don't know also what exaggerated systemic immune response means. There's different ways of assessing that as well. And those are the reasons why there is some heterogeneity among trials and obviously no unifying result that can help us know what to do at the bedside. And I also added here timing, which is not that well addressed, but I think at the very least it is as important as severe pneumonia and severe immune response, because in general, in critical illness, timing is extremely important. So whatever treatment is delivered sooner rather than later, the success rate is better, the outcomes are better. So besides these three issues, severity of pneumonia, severity of inflammatory response, and timing, there are multiple other issues that may decide whether corticosteroids may work for severe pneumonia. Perhaps different pathogens would have different response. Until COVID, most people did not use corticosteroids in viral pneumonias. And then obviously situation changed a little bit in COVID. There were no actually randomized clinical trials. There were some observational studies showing that people with influenza who got, steroids for ARDS later on in the course did poorly. So the notion was, okay, so that's not good because steroids will just, weaken the immune response to the viral disease and perhaps people will do worse. How about non-infectious etiology of pneumonia? For example, massive aspiration can lead to ARDS, shock, and fatal outcome. Can steroid help even if there is no infection, right? Then what are the characteristics of the host? Is it a younger individual? Is it an older individual? What is the immune system in certain individual, etc.? Then what corticosteroids? Different trials use different formulations of corticosteroids. And then in what dose, for how many days, and then the delivery. Most of the studies use intravenous medications. My study that I'm currently conducting, we're in the 6th year of randomized controlled trial. We actually use inhaled corticosteroids to see whether that will help prevent respiratory failure in patients with severe pneumonia. And then I've already mentioned that outcomes differed. So, do we study mortality? Do we study how long patient will be intubated or how long they're going to be in the hospital, etc.? And also systemic corticosteroids have major adverse effects. Some of them are hyperglycemia, perhaps infectious, superinfection or infectious consequences with readmissions to the hospital. Then acutely, especially elderly, they can have delirium and insomnia in the hospital, etc. So this all matters when deciding whether we should use it or not. The current guidelines, so I would say within the last 5 years, kind of evolved. American Thoracic Society and the Infectious Disease Society of America about 5 years ago did not recommend routine use of corticosteroids in community-acquired pneumonia. Then in 2023, European Society, both of respiratory as well as intensive care, as well as Latin American Lung Association, they thought that corticosteroids should be used if there is shock present, although they commented that this was a low quality of evidence. And they did not think that this applied to viral pneumonia such as influenza, severe acute respiratory syndrome, and Middle Eastern respiratory syndrome. And also given hyperglycemia, which was seen in most of the trials, uncontrolled diabetes also was not, people with uncontrolled diabetes were not recommended to receive adjuvant corticosteroids. And then last year, the Society of Critical Care Medicine came out with recommendation for steroids in ARDS, shock, and pneumonia. And within the pneumonia area, it was recommended strongly that patients with severe pneumonia receive corticosteroids. So obviously the guidelines evolved, and this may be the reason why. Dr. Torres from Barcelona did trial, not the first trial on the topic, but certainly the first in the last 10 years, because this topic was popular even 20, 30 years ago, although no high quality trials were done at that time. Nevertheless, Dr. Torres enrolled about 120 patients over 8 years. Very slow enrollment, although there was only 3 in 3 hospitals. Nevertheless, he used methylprednisolone 1 milligram per kilogram for 5 days. This was started within 36 hours of patients meeting criteria. And he also measured CRP. So the cutoff for CRP was 150. And then he noticed that people who had elevated CRP more than 150, and when they received steroids, there was actually improvement in combined primary outcome. Basically, there was decrease in treatment failure. There was no difference in mortality, but the combined outcome had 5-6 different things that matter, shock, intubation, length of stay, and also radiological improvement. And then when they analyzed the data, most of the people actually had improvement in their x-rays and not necessarily statistically significant improvements in other pertinent patient-centered outcomes, although the study was severely underpowered with only 120 patients, so hard to tell. But I think he set really very important precedent. This study certainly didn't tell us that we should use steroids, but I think that he basically, started, the whole sphere within the research in critical care with this kind of special topic of corticosteroids and pneumonia and respiratory failure. And then the COVID hit in 2020, and British UK researchers were able to quickly do the study where they used dexamethasone 6 milligrams for people with COVID, and they noticed that there was small mortality benefit overall in patients who received dexamethasone. And then when they did the granular analysis, it looks like this was mostly due to benefit in patients who required mechanical ventilation while there was also small benefit in patients who required supplemental oxygen versus not. Now, we never were able to actually get the details of that. What that means was that, 100% of oxygen on non-rebreather mask, or it was a 2 liters nasal cannula oxygen. We have no idea. And then another thing is, why would anyone with COVID that didn't need oxygen at all be even admitted, let alone treated with supplemental steroids? So a lot of questions, but nevertheless, this really changed the practice to the point that everyone that came after June 2020 to the hospital basically started getting steroids, or almost everyone, if there was no contraindication. In 2022, Dr. Meduri, who studied steroids for the last 30, 40 years, I think, randomized people on methylprednisolone 40 milligrams with a 20-day taper. It was started a bit late, within 96 hours of admission, of meeting actually criteria, not admission. And they also have slow recruitment. I think they reached about 40% goal. They were planning to do 1,400 patients. And then they were underpowered, and because of slow recruitment, they stopped. And there was no mortality change, no change in adverse events, although people on steroids were needing more insulin. So, there was no hypoglycemia, but they required more treatment for sugar control. Nevertheless, this was a negative study. And then Cape Cod in 2023, several hundred patients, I think 600 patients or so, they were randomized to receive hydrocortisone, 200 milligrams, I think 4 times 50 dose, so every 6 hours, 50 milligrams of hydrocortisone. And then depending on how people improved, they got either 4 days or 8 days of that dose. And then if they got 4 days, then they were quickly tapered. If they got 8 days, then they were tapered over 14 days. Nevertheless, they really had early initiation, which is a very good and hard thing to achieve in a clinical trial. And they did show decrease in mortality in people that got steroids and with increased glucose. This study was stopped for efficacy after the second interim analysis. So again, they did not necessarily reach the necessary power for the study, but for the ethical reasons, they could not consider the study. For the statistical reasons, stopping study is never a good idea, but obviously for ethical reasons, you may need to do that. And last but not the least, VMAP-CAP was published a few months ago. They also used hydrocortisone. This is a pragmatic, adaptive trial over many hospitals, many countries. The main characteristic of this trial is that they actually used several interventions. So, the trial is not only on steroids. There could be 3, 4, 5 interventions that the patient is enrolled in the same time. And they had a problem. They had a big problem because their randomization sequence was erroneous. So they gave actually steroids to almost 5 times more people than the placebo, because they actually were not aware of that. They thought that half of the people on placebo while they were getting the regular medication. Obviously, there were a lot of regulatory issues with this, etc. But nevertheless, this study did not show mortality. And interestingly, even the people with shock, we know that they need hydrocortisone, honestly, because it helps with vasopressor responsiveness, and it's improved in almost every other study outcomes. And it did cut down duration of the shock, but really the people with shock fared the same, and the mortality was not different, which also puts a little bit of a question mark in terms of why this trial showed what it did. But nevertheless, we went full circle, right? And we still don't know then whether the corticosteroids should be used for pneumonia in most people. A couple other studies that are worth mentioning. Dr. Adeyemi is mentee of Dr. Gajic. So Dr. Gajic has been very active in this field as well. What they did is they collected retrospectively data on the patients that were admitted with pneumonia and that had measured CRP level within 48 hours and that received steroids, right? So then they created two groups of people, those who were steroid concordant, meaning they had high CRP, so, they should have received steroid, and those who had low CRP, so they did receive steroid, but perhaps they shouldn't have. And they really showed that steroid concordant patients had better oxygenation starting on day 3 and onward, and lower duration of ICU and hospital length of stay. And then there are two meta-analyses, one from last year and one from this year. Just to speed up, I don't know what time. Well, I think I'm okay with time. Anyhow, the CHIMA in 24 looked at 15 randomized controlled trials, 3,200 patients. There was overall decrease in mortality if the steroid used was hydrocortisone and if pneumonia was marked as severe. Again, this is different trials, so there was some heterogeneity in terms of what was considered severe pneumonia. And they noticed also that younger patients fared better, and that there was decrease in shock, mechanical ventilation, hospital, and ICU length of stay. And this, I think, did contribute to recommendations also from Society of Critical Care Medicine for use of steroids. And then Smith in 2025, just recently, I think a few months ago, published a meta-analysis looking into individual patient data. And also they looked at the heterogeneity of the treatment effect, because regardless of medication and disease, there is no such a combination where that everyone with a certain disease will respond to certain medication. There is so many heterogeneity involved that there is no 100% cure for or treatment for everything. So what they did look is they did risk modeling for severity of pneumonia using pneumonia severity index, which is just one of many different ways to characterize pneumonia as less severe versus severe. So they compared 1, 2, and 3 index, which is less severe pneumonia. One would argue these people don't even need to be in the hospital. At least that's how it's in the United States, versus index 4 and 5, which is severe pneumonia, people that actually get admitted to the hospital. And they also look at the predictive effect of the CRP. Does that cause heterogeneity in outcomes relative to the treatment of corticosteroids? And what they showed is that overall, in all trials, among all patients, there was decreased mortality, slightly, but still decreased mortality. And then they looked at the CRP and noticed that if their CRP was elevated, and their cutoff was a little different because they, the way that they did the study, they did validation and then, they did derivation and validation of the predictive effect. So it turned out that about 200 milligrams per liter CRP was predictive. So if the CRP was above that threshold, there was significant decrease in mortality, and the effect was positive, and the interaction was also statistically significant. And then if the CRP was less than 200, there was really no benefit of steroids in the outcomes. And then they also look at pneumonia severity index, and they did not see heterogeneity in treatment effect relative to this. And there's different explanations about this and reasons. The severity of the disease is a continuum, and there was only one indication whether you're severe or not on admission. So I think that certainly contributed to why not the severity didn't show to be a significant contributor here. And yes, patients did have hypoglycemia and also secondary infections, which doubled the readmission. So this is the data that we have, I would say the most important data. There is more than this, obviously. So what do we do with this now? I think in summary, certainly we need more research. There's no question about it. I think it's fair to say that systemic corticosteroids have shown full range of effects from helpful to harmful when used as adjuvant therapy in pneumonia. We need further studies and to basically focus on specific groups of patients. And then both research as well as the clinical approach, I think, should be directed towards people who have elevated inflammatory biomarkers. The CRP is probably the most common one, used one. So the people with elevated CRP, if there are no contraindications and if they have severe pneumonia, should receive corticosteroids. Also, severe pneumonia itself, which can be identified much sooner than this, the lab result, although there are some quick turnarounds for the biomarkers currently. But nevertheless, I don't know how long it takes in Bosnia to get the CRP back. Probably it's better to treat than wait for the CRP if someone has severe pneumonia. But I don't know, you probably know better how long you would get it from the lab. And then also people with respiratory failure, if they're already on advanced respiratory support, that is very closely tied to the severity of underlying pneumonia, possibly. And therefore, these people should be strongly considered for treatment. The treatment should start as soon as possible. I think 24 hours would be ideal, or within 24 hours of admission to the hospital. And perhaps 48 hours also may be beneficial. And then it is hard to tell what would happen if someone is started 3 days or later on steroids. Probably steroids would not have as much benefit. And then certainly we have to weigh also adverse events. And so not everyone, even if they meet these criteria, perhaps not everyone will be able to receive steroids. And I will take questions next. That's it.
Thank you, Dr. Festić.
Thank you.
Question. Any question?
Da li se razmatralo procjena vrijednosti proteina od ovih uplava, odnosno uključivanje kortikosteroida prema vrijednosti kortikosteroida? Da li samo gledamo CP kao pneumonia ili kortikosteroid ikada razmatra? Obzirom da mi nemamo neke tačne podatke kako će biti kortikosteroidi, pa da li je taj parametar?
Adnane, možeš li ponoviti pitanje, jer je malo, nisam dobro čuo.
Da li se, znači, specifično pitanje procalcitonin, CRP...
Dakle, procalcitonin je malo različit od CRP. Mi u ovoj mojoj studiji ja koristim procalcitonin da odlučim da li pacijent ima pneumoniju ili ne, odnosno da li ima infectious pneumoniju ili ne. I elevated procalcitonin može da također contribute, da doprinese u ukupnom dojmu da li se radi o koji severity of the disease we're looking at. Tako da studije nisu koristile procalcitonin. Ja nisam vidio da ima studija koje su koristile kao trigger za kortikosteroide, ali ja personalno koristim ga kad je naručen. Dakle, ne naručujem ga u ovoj svojoj studiji specifično za pacijente, ali ako već pacijent ima procalcitonin, ja uvijek gledam i to mi je dodatni jedan kriterijum ponovo u big picture na koji gledamo da li pacijent ima inflammatory response i zajedno sa ostalim karakteristikama da li zavređuje treatment. S tim što ja ne znam, pošto je studija slijepa, blinded, ja ne znam ko dobije pravi ko placebo, ali ako pacijent ima elevated procalcitonin levels i sve ostalo looks good, mi također gledamo naš osnovni kriterijum za severity of pneumonia is requirement for oxygen. So not to complicate and confuse everyone, but basically we've done a lot of research showing that if you need oxygen, you're in trouble. And more oxygen you need, more you're in trouble. And then in addition to that, if you have inflammatory biomarkers such as CRP or even procalcitonin, you probably should be at the very least in the trial, and hopefully that will help us decide after the publication of results to know whether patients will need corticosteroids. But yes, we need to focus on the groups of patients that will benefit and not even hope that everyone will benefit from it. There's definitely not, there's no single medication that everyone will benefit from. So we need to find out who benefits from steroids as adjuvant treatment.
Moje pitanje je, a dob koju ulogu igra, mislim, sigurno je razlika ako je neko starije dobi, ima brojne komorbiditete, njemu kortikosteroidi će više štetiti nego.
Dobro pitanje.
Sam ja inače endokrinolog, pa onda...
Ja, dobro pitanje. Nije baš tako jednostavno, ali slažem se da kod starijih ljudi sa različitim komorbiditetima vjerovatno neće imati takav odgovor. Mislim da je Cape Cod studija pokazala da su mlađi ljudi imali malo veći odgovor na steroide, odnosno bolji efekat. Mislim da nije kontraindikacija ako je neko stariji i sa komorbiditetima, ali mislim da bar po onome što je pokazano, da će mlađi ljudi i bez komorbiditeta vjerovatno imati bolji efekt. Mogu li ja pitati publiku, audience, da li koristi se, da li vi koristite kod teških pneumonija, dakle u intenzivnoj njezi, koje je neko u respiratornom distresu, da li se uz antibiotike daju sistemski kortikosteroidi u našoj regiji?
Možda je ovo prilika da se, maybe opportunity to talk about how in a practical manner we use the steroid, like Dr. Festić, how you use, for example, you having the female 49-year-old 60 liters and 70% FiO2 high flow nasal cannula, diabetic, obese, and multilobar pneumonia. She came of 3 days of the symptoms, and she's been admitted from the ED to ICU. Antibiotics, obviously, and resuscitation, and then the steroid. How you would approach it?
Again, it sounds like she has severe pneumonia, given that the degree of respiratory support, advanced respiratory support, is present. So in my mind, that's the severe pneumonia. If she just got to the hospital, this is the right time to try steroids. I usually use small dose, so 40 milligrams of methylprednisolone IV. I don't think that there is much difference between dexamethasone, hydrocortisone, or methylprednisolone, other than hydrocortisone having a little more mineralocorticoid support. So certainly in the septic shock, hydrocortisone may make more sense. But if you start early and if it's only pneumonia before the multi-organ failure and septic shock, I think low-dose steroids should be tried unless it's contraindicated. So I don't know how, is the sugar 550 or that's different in Europe, obviously. But, that would be, I don't know, if the sugar is 25, right? I think that would be comparable. Or the sugar is relatively controlled, right? Do we suspect viral syndrome versus bacterial? Is it lobar pneumonia or not? Is there a component of congestive heart failure? This is where procalcitonin CRP certainly can help. But I'm obviously biased. I have a low threshold to start steroids for as an adjuvant treatment in pneumonia.
And how long you will keep the patient, presuming that next
I don't.
she's on less oxygen and she's doing better.
My approach is I cut very quickly. I basically, if patient is getting better, I'm cutting down the steroids and switching to obviously oral prednisone as soon as possible. That would be my clinical gestalt. Whether it's right or not, I don't know, but I don't think that people need long taper. The people that were not on prednisone or steroids that are naive, they don't need to be treated for 20 days like in some studies. A very, very quick taper based on the clinical improvement.
Thank you, Dr. Festić. Thank you I know it's midnight and over, I guess, at your place.
Yeah. It's okay. Thank you. Pleasure. And
Thank
I'm
you.
really, really sorry that I'm not there.